Welcome to the GeriPal podcast. This is Eric Wadera.
This is Alex Smith.
And Alex, who is our special guest today?
Today we have a guest from the University of Washington. We have Randy Curtis, an esteemed and established palliative care researcher. He's professor of medicine and pulmonary critical care up there and director of the Palliative Care Center of Excellence. Welcome to the GeriPal podcast, Randy.
Great. I'm excited to be here.
So before we get into our topic of the day, we always ask our guests, do you have a song for Alex to sing?
I do. I consulted my 14-year-old daughter, and we picked Supermarket Flowers by Ed Sheeran.
And I understand that you saw Ed Sheeran perform on your sabbatical in Paris recently. Is that right?
We did. Yeah, my daughter and I went to see him live in Paris. It was pretty awesome.
Is he the one who likes to rap occasionally in his concerts?
He does. He raps, and he also does the entire concert as a one-person show.
Oh, really? Wow. Yeah. How was it?
It was awesome.
Yeah, he's the kind of performer who could pull that off.
Yeah.
We're going to have Alex rap this song now.
Well, we will not. But interesting side note, this guitar I play is the same kind of guitar that Ed Sheeran plays. He plays a 3/4 size guitar. So for those of you who are watching on YouTube, if we get this up on YouTube, this is Ed Sheeran's guitar. And I am by no means, Eric, equating myself to just head off your next comment with Ed Sheeran.
YouTubers, you are about to see the magic happen.
That's right. Well, that was the wrong chord. We'll start again. I took the supermarket flowers from the windowsill. I threw the day-old tea from the cup. Packed up the photo album Matthew had made. Memories of a life that's been loved. I took the get-well cards and stuffed animals. Poured the old ginger beer down the sink. Dad always told me, don't you cry when you're down. But Mum, there's a tear every time that I blink.
Well done.
Is that Ed Sheeran?
That's just like Ed Sheeran.
Right. Yeah, right.
It's just like being in Paris with Ed Sheeran, right, Randy?
I got a tear in my eye.
So we were hoping to talk to you about your recent JAMA IM article titled Effect of a Patient in Clinical Communication Priming Intervention on Patient-Reported Goals of Care Discussions Between Patients with Serious Illness and Clinicians. Well, that was a long title.
It was
So maybe before we talk about this particular article, maybe we can just take a step back and just think, how did you get interested in this? Because this is really interesting. Like, we're using a priming intervention. Like, just tell us how you got interested in the topic of communication in the ICU.
Yeah, well, this study actually we did in
outpatient.
Sorry.
And I got interested in this area a long time ago in medical school, actually, watching. I went to medical school in the late 80s, and HIV had just hit Baltimore, and watched a lot of young men dying of a terminal disease at the time, and just seeing how incapable our healthcare system was at communicating with them. And then also kind of simultaneously watching some amazing doctors do amazing jobs. So it's clearly that it can be done, and yet most of the time it isn't done well. And so I got very interested in trying to figure out, how do we understand this better and how do we make it better?
Yeah, and this issue of priming intervention, like patient activation, it's a different sort of take, right, on how to promote advanced care planning, priming patients to talk with their physicians, and in this study, priming physicians to some extent as well. Where did the impetus for that component come from?
Yeah, I also have come to believe that we really need to have a bilateral approach to this, that we need to prime both patients and prepare them for the conversation, and prime physicians or nurse practitioners to do this as well. And I just felt like if we came at it at both angles and prepared both parties, we were more likely to get successful conversations happening.
So when we say Prime, it's not Amazon Prime, right? This is, what are we actually talking about when we say priming people?
Yeah, I think this is a really important point because this priming, this preparing people, getting them to think ahead of time about, well, particularly patients, getting them to think ahead of time about what's important to them and what their values are and how they want to talk about this. Getting clinicians that information so that they're also prepared. I think this priming intervention does not work, will not work, can't possibly work if clinicians don't have basic skills. So I believe that the support trial, the famous support trial from the 1990s, was a priming intervention that my hypothesis is it failed because in the 1990s, this was not a basic skill that physicians had. And I think, fortunately, we're not where we need to be, but I think in 2018, the physicians and nurse practitioners have the basic skill, and we can just prompt and prime and help guide them, and we'll get somewhere that we couldn't have gotten in 1990.
And when you say basic skill, you mean communication skills about goals of care?
Yes. Yeah. If they had no skill at all,
yeah,
then this intervention, I believe would fall flat and could even do harm. But if they have the basic skill, then helping them do a better job and prompting them to do it with this patient today, I believe can be successful.
That's terrific. So let's talk about this particular study and talk about the setting in which this occurred. So could you talk a little bit about the population that you studied here?
Yeah. So we were interested in patients with a chronic serious illness. We identified patients with a whole series of different chronic and serious illnesses. And we were targeting patients who, on average, had a median survival of about 2 years. And so, this is not advanced care planning with healthy patients. This is not planning for end-of-life care. It's in the middle. It's sort of the beginning, early goals of care discussions for people in whom these decisions are not facing them today, but might be soon. And we did this in the outpatient setting as well.
And how did you determine who fit into that 2-year eligibility?
We had a series of different eligibility criteria for different diseases: oxygen-dependent COPD, metastatic cancer, interstitial lung disease with a total lung capacity less than 50%. So for each, class 4 heart failure, for each disease, we sort of came up with criteria that we thought roughly put patients in that group.
Mm-hmm. And were these patients who had not previously had a goals of care discussion?
Well, that's a good question, and we did ask patients if they'd had a prior goals of care discussion, but we did not exclude them if they had. So about my recollection is about 40% told us yes.
Mm-hmm. So and these are outpatients, and it was
right.
At multiple different institutions. Is that right?
Yeah, it was throughout the Seattle area. So it included UW Medicine, that includes two academic hospitals and 2 community hospitals. Then we also went to a large community hospital system here as well.
Mm-hmm. And then you recruited outpatient docs to participate in this study.
Right.
What was that difficult? Were they enthusiastic? What was that like?
Well, it wasn't easy, I would say. We had a participation rate for the outpatient docs or nurse practitioners. It included some nurse practitioners as well. Our participation rate was 27%, which I think tells you right there that, most doctors in their outpatient clinics are not signing up to do extra work. I'd like to believe that it would be much higher if it weren't a study. If we were actually implementing this in practice, I think we would probably get higher participation rates. I think part of the reason it was low is because we're saying, hey, would you be willing to participate in this study? It's optional to you. And good news, you get to fill out some surveys.
Right. In that light, 27% actually may seem pretty good. Yeah, right?
Well, that's not bad.
Right. Okay, so let's talk about the study design was a randomized trial.
Yes.
Can you talk about the intervention and the control conditions?
Yep. So for the intervention, what we did is we surveyed patients ahead of time to ask them questions about whether they had these discussions, whether they wanted these discussions, what they saw as the main barrier to this discussion with their doctor, and what their current values were and preferences were. And then we collated all that information into this one-page, what we call a Jumpstart Tips form, which had two different forms. One form went to the patient and said, you have a doctor's appointment coming up. We are encouraging you to have a conversation about goals of care. It's easy. Here's how you might start it. And here's what you told us on the survey about your goals and preferences. And then for the doctor or nurse practitioner, similar form, but it said, your patient's participating in this study. Either they are interested in having a goals of care discussion, or they're not, and here are their main barriers and ways that you might want to still address that, even though they told us they weren't interested.
Could you give an example of like what kind of barrier was common, and how might the clinicians overcome that? And I understand you may have integrated with VitalTalk here.
Yeah, we did. Tony Bach was one of the investigators on this study and helped us a lot with thinking about how to address these barriers. And so, for example, one of the barriers was, I'd rather focus on staying alive than talk about end-of-life care. Fairly common barrier. And the suggestion was something along the lines of, this is a difficult topic for this patient. Oftentimes, patients who don't want to talk about this, it's better to approach it indirectly and talk about patients with a disease like you rather than you. That's just one example.
And remind me, how did the clinician get that feedback again? How to address this?
They got a one-page, it was a piece of paper.
Yeah.
They got by email 1 or 2 days before the clinic appointment, and then a paper copy showed up in their box in clinic on that day.
And the suggestion was also in there on how to deal with.
Yeah, it's a one-page. We have examples in the on the website, but it's a one-page document that says, provides maybe a little too much information. Frankly, that's some of the feedback we got, but it provides all this information on one piece of paper.
And in addition to that, did the clinicians get any other goals of care training on how to have these discussions?
We didn't control that, so many of them in our system have had some training, and some will have not. We don't have a systematic way, or at least we didn't when this study was being done. We didn't have a systematic way to train physicians in this that was in place. So that would be very hit and miss.
Mm-hmm. And what were the control condition in this case?
Yeah. So the control condition, I think, is important to understand because it was what I like to think of as sort of usual care plus or enhanced usual care, in the sense that the control patients also filled out the same surveys that asked them about having these conversations, barriers to these conversations, what's important to them. Mm-hmm. And I believe that those surveys actually prompted some discussions. And so if you look at our control group, 31% of the control patients had a discussion about goals of care on a routine clinic visit, mm-hmm. which I believe is much higher than in routine practice. I think it's probably less than 10%. Mm-hmm. So I do think there was some prompting that happened by virtue of filling out the survey.
Mm-hmm. It's like a mini jump start.
Yeah, it's like part of a jump start.
I don't know what that would be.
It also reminds me a little bit of Rebecca Sudori's work with Prepare for Your Care. Like kind of flipping the classroom a little bit, getting people to think about this before they talk to their physicians. Rebecca's work also includes a lot of videos, working through 5 different steps and patient-friendly formats to get people to start thinking about their goals of care and create an action plan. Mm-hmm. It sounds like there's components of that here. Is that right?
Yes, I would say that that's right. I would say that the patient-facing part and patient prompting part is similar, although in our intervention, I would say it's much less detailed. that's really the focus of her intervention is patient education and engagement. And for us, I think it was a smaller part and a shorter process for the patients.
Mm-hmm. And the focus of this intervention was more about priming the patient and the doctor to have a high-quality conversation, high-quality communication in the office, doctor or nurse practitioner, the clinician. Whereas Rebecca's work is much more focused on doing pretty much everything in the outpatient setting. And yeah, it'd be great if you brought this to your doctor as well.
Yeah. Although her work has also prompted these discussions. So she showed it in one of her recent randomized trials that having the patients do prepare for your care and then asking them to bring them into the clinician they did that and it prompted discussion. So I do think there's some overlap.
So let's now maybe talk a little bit more about what you actually found in this study doing this priming.
Yeah. So our primary outcome was whether, in fact, we could prompt these discussions. And we looked at that. The primary way we looked at that was to ask the patients. We also looked at what the clinicians documented in the EHR. And in addition, we asked the clinicians on surveys whether they talked about it. And our primary outcome, we did see an increase in patient report of these discussions, 31% in the control group and 74% in the intervention group. We also saw an increase in clinician documentation in the EHR from 17% in the control group to 62% in the intervention.
Wow, those are big differences there.
Yeah, it's hard to say that there's nothing going on because there's definitely something going on there. Yeah.
Right. Yeah. Yeah. No, I was very pleased with that. I thought that was really terrific. And then we also asked patients to rate the conversation that they had with their clinician using a survey instrument called the quality of communication. And the patient's rating of the quality of the discussion also increased significantly.
And you had another outcome here that is sort of the holy grail of palliative care, which is goal concordant care. Can you talk about and the issue going, and I'm sure you and many others who may be listening are aware of, is how do you measure that? And you chose to measure it a specific way based on support. Could you talk about that selection?
Yeah. So I think you're right that it is the holy grail of how we measure goal concordant care. And I would be the first in a long line of people to say that there's no perfect way to measure this. And that there are real conceptual challenges to measuring whether care delivered is goal concordant for lots of reasons, an important one being that patients' goals can change. We chose to measure it with this question that was first developed for the support trial that we talked about earlier, done in the 1990s, that asks patients to pick between two choices, what is clearly, in a sense, a false dichotomy, but it asks them to choose, if you had to choose right now, would you prefer a course of care focused on comfort, even if it means not living as long, or a course of care of living as long as possible, even if it meant not being as comfortable or not being comfortable? And it's a false dichotomy because, of course, everybody wants both, right? Everybody wants to live as long as possible, as comfortably as possible. But it's an approach that I personally like. Most of my colleagues hate it. Most palliative care doctors hate it. Most palliative care researchers hate it. I like it, and I like it because it's not a real choice. It's helping you understand somebody's priorities when faced with trade-offs. And so I think as a research tool, I think it's actually potentially quite helpful. And so we ask them first, what would you prefer? And then we say, given the same two choices, how is your care focused now? And we defined goal concordant care as care in which they say, this is what I prefer, and my care is focused in the same way.
Well, it's interesting too, because I actually use that a fair amount in my clinical work. And I think I got this from a fellow who got this from Rebecca Sidori, is kind of using a spectrum. Like on one hand, we have patients that we care for who would want to do everything they can to try to prolong their life, even if it causes some discomfort. On the other hand, we have patients whose primary goal is just to be comfortable, even if it means they may not live as long. And then in the middle, we have most patients where they fall somewhere in the middle. Where do you fall? It sounds like it's a similar thing here. We're just taking out the middle. If you had to make a choice right now, where would that be?
Right. And I think from a research and measurement perspective, taking out the middle is really important because the vast majority of the population, of course, is in the middle.
Yeah.
Right.
Whether you're a 3.8 or a 4.2 on a 5-point scale is pretty meaningless from my perspective. But when you do this sort of forced choice exercise, most people will put their money down on one or the other. There are some people who won't, who say, I don't know. And we chose, from a research perspective, to define them as not receiving goal concordant care. But most people in the study chose one or the other, and frankly, the majority chose comfort over longevity.
Mm-hmm. And it's in contrast to something Steve Pantelat said on this podcast when he was talking about we asked him, how do you define palliative care? And he says, clinically, I say to patients, my goal is to help you live as well as you can for as long as you can, right, which is sort of the synthesis of those two goals together.
Exactly.
I wanted to ask you about, just sticking with the goal concordant care, if you could talk about the outcomes there in this study.
Yeah, so we looked at it overall in all patients, and we did see an increase in the proportion who reported goal concordant care at 3 months after the intervention, the target visit where the intervention was delivered. But it wasn't statistically significant. The p-value was 0.08. And then we then looked at an a priori chosen subgroup of patients whose goals were stable between 3 months and the last time we measured it. And we chose that subgroup because this is what we talked about before, that if patients' goals are changing, it's pretty hard to align their care with their goals. And so we said, well, if their goals were stable, did we see a significant improvement? And there we did. We saw a significant increase in goal concordant care in amongst that subgroup with stable goals.
Yeah. So this is a really exciting, encouraging study. I guess my next question is how much does it actually mean? Because ultimately what we care about is improving the quality of these conversations so that we can improve patient experience in the setting of serious illness. So we have some signals from the patients that maybe there was more goal concordant care. Yep. And we certainly have improvement in communication, improvement in documentation. Yep. What are the next steps here in the outpatient setting, and how far? Like, what would you ideally measure if you could?
Yeah, well, I think you're absolutely right that that's the key question: is does this change care, or does this change the patient's experience of care? And we don't know based on this study whether it changed care. We had we had almost 250 patients, and yet only about 60 died in the 6 months that we followed them. And so we really weren't powered to be able to see whether it changed the care they got at the end of life. That's what I'd like to know. I'd like to know, did it change the care they got, and did it change their experience of their care at the end of life? And you'd need a much bigger study. I also think I see this as a sort of a proof of concept study. I also believe that it's probably naive to think that doing this once over the course of a patient's illness is going to have dramatic effects on the care they receive. I think we know from our experiences as palliative care providers that these conversations are not things that you generally can have once and be done with, but rather something that needs to be continually updated.
But let's say you sold me, Randy. Let's say I'm really I'm down for priming. Is this ready for prime time? Should I be using this? How can I use this?
Yeah. So if you say to me, I'm in charge of a healthcare system, the healthcare system will do whatever I tell it to. And I believe that having these conversations is important, and I want these conversations to be happening in my healthcare system. then I say, yes, it's ready.
Because I work at the VA.
Roll it
And
out.
nationally at the VA, we have a new policy around life-sustaining treatments where any high-risk patient, who pretty much everybody who would qualify in this study would qualify for our policy, should have goals of care discussions. What would that rollout look like if we want to do that like VA-wide?
So to roll this out VA-wide, you would need to have in place, which you do, a system to send people surveys and to collect the results, and then it can automate these jumpstart forms. And then you'd have to have a system in place to get the jumpstart forms to the patients and the clinicians before a target visit.
And let's say I'm interested in these jumpstart forms. Are they available? Like, can I actually get them somewhere?
Yeah, there's examples of both how we created them, the algorithm that we used to go from the survey to the jumpstart form on the JAMA Internal Medicine website. And then there's also two examples, a clinician example and a patient example.
And what proportion of patients actually did everything, completed all the surveys, and then, in other words, I'm trying to get a sense of, like, do you have a sense of how burdensome this was and what the sort of uptake was on the patient side?
Yeah, so that's a good question, and that would be a big issue if you did what I just said as a VA system and said we're gonna send these out, we're gonna get them back, we're gonna put them in, in this research study with funding from PCORI to do this study and staff to send these out and bug people to send them back, we had 59% of eligible patients agree to participate. And then we had survey results on, depending on when, somewhere between 70 and 80% of the patients.
Wow.
So with that staff in place, you could reach somewhere around 50% of eligible patients. Reach meaning they fill out the survey, they send it back, you get them the jumpstart form. But I think that the key there is with that staff. And what I just said to you about what you would need to roll this out in the VA didn't include that level of staffing.
And it sounds like you mentioned before there's some lessons learned that you have, like maybe the forms are a little bit too much or too detailed.
Yeah, we did qualitative interviews with patients, family members, and clinicians to get feedback on the intervention. And that was a common piece of feedback was it was too much. There was too much information there. So in our next iteration of this, I do want to simplify the forms. And I also think that the tips that we provide, I think they were good, but I think they could be improved. And so if I were going to roll this out in a healthcare system, I'd bring together palliative care experts and others and say, hey, look at these tips and tell me how to make them better.
I saw that congratulations, you got an NPCRC Pilot Award, and you're going to be studying this same intervention, my understanding is, in an inpatient setting. I wonder if you could tell us more about that next step, speaking of next steps, and why you decided to move from the outpatient setting to the inpatient setting.
Yeah. So for me in this intervention, I think there are really two next steps. One, as you've said, is to try this on the inpatient side. And we're very appreciative to NPCRC for funding this pilot. I think it really needs to be piloted because I think we don't know how this is going to work on the inpatient side. The inpatient, setting is everything is time compressed. Everybody's very busy. I do know that from our preliminary data that there are a lot of patients who are admitted to the hospital who should have a goals of care conversation and don't. Mm-hmm. So I believe the opportunity is there to prompt these conversations in the inpatient. But whether we can successfully do that in a setting where, at least in our city, everybody's focused on getting the patient discharged as soon as possible. And so I think that'll be a challenge, and I'm excited to try it on the inpatient side.
Mm-hmm. And sometimes you find, surprisingly, that having these conversations, especially early in the course of hospitalization, may actually lead to shorter lengths of stay.
I think that's right. And it may lead to palliative care consults and hospice referrals. And I think that's right. And that would be the goal, to look to see if we can do that. The other thing that I really want to do, since you asked about next steps, and have written a another PCORI grant to do that, is to compare. So this intervention requires that we get a hold of patients and survey them and then use that information in the Jumpstart. What if we just designed a more generic Jumpstart that didn't have to go through that whole process, and compared the patient-specific Jumpstart to a more generic Jumpstart? And that's what we want to do in a comparative effectiveness trial, because that would be a lot easier to roll out in a healthcare system if it was as effective. But I don't know. I think I don't know whether it'll be as effective.
Right.
Well, my last question, because we're talking about next steps, and I know the next step that you really want is Alex to do a little bit more Ed Sheeran.
That's true.
But is there anything else that you'd like to talk about while we have you online?
I guess the other thing that I would say is that I think that there are a lot of exciting interventions out there, like Rebecca Sidori's Prepare for Your Care that you mentioned, like the serious illness checklist that the group from Harvard is doing, like the Vital Talk teaching. And what I would think would be fabulous is if I think that all of those things could be used together. I don't think it's an either or. I don't think they're in competition, but they all take somewhat different approaches. How do we take the best of each and create a system that we're really prompting, guiding, and helping these conversations to be the best they can be? That's my dream for 2020.
I think that'd be great, because as a provider, you can sometimes you feel a little bit overwhelmed when there are too many choices of what should I do? Should I do Rebecca's Prepare? Should I do priming? Should I do
the vital decisions, the video decision aids? Andrew Valandez, who's on this podcast.
Never mind. I'll just go home and too many questions. I can't take it.
Paralysis of choice.
Yeah, we'll focus on diabetes targets instead.
Right. Well, that's great. Thank you so much, Randy.
Yeah, I enjoyed it. Thanks for having me.
Well, how about before we end, Alex, do you want to give us a little bit more Ed Sheeran?
Sounds good. I took the get well cards and stuffed animals, poured the old ginger beer down the sink. Dad always told me, don't you cry when you're down, but Mum, there's a tear every time that I blink. Oh, I'm in pieces and it's tearing me up, but I know a heart that's broke is a heart that's been loved, so I'll sing hallelujah. You were an angel in the shape of my mum. When I fell down, you'd be there holding me up. Spread your wings as you go, and when God takes you back, he'll sing hallelujah, you're home.
Hey. Couldn't tell if you were done with that. Thank you, Randy, again for joining us, and for all of our listeners for joining us this week. We look forward to our next podcast next week, too. If you have a moment, please take a little step and just rate us on your favorite podcasting software, whether it be iTunes or Stitcher or anything else. And with that, we'll end. Thank you.
Thanks, Randy. Bye.
Thanks. Bye.